Hello. So I'm excited to be joined today by my colleague, Andrew Petersen. And since I joined Forum Health Partners, which is an organization of integrative practices throughout the country now, I was lucky enough to have Andrew become one of my associates. And Andrew has some experience in a therapy of medicine that I've been very excited about. I've known about it for quite a long time, but it's only been since I've joined Forum and affiliated with Andrew that I've really had this low dose immunotherapy that we're going to be talking about today in my toolkit as one of the tools I can use for my patients that I'm treating for chronic complex illness. But I wanted to start off before we get into this discussion about low dose immunotherapy. I wanted to give a little bit of an introduction on Dr. Petersen so that more of my listeners and viewers will have a better knowledge about him. But Andrew, you specialize in the conventional approaches, or excuse me, to patients when the conventional approach to treatment falls short. And these kinds of approaches would include various hormonal imbalances such as hypothyroidism, chronic fatigue syndrome, diabetes, fibromyalgia, metabolic disorders, Lyme disease, and neurodegenerative conditions. And I know you get involved in a lot more than that because we've had many discussions. Before you joined Forum Health, you shaped your treatment philosophy as a hospital chief of staff in rural Texas. And I know you and I share a background of being Texas trained.
That's right.
You also have 15 years of physician experience. So since you've become more interested in integrative medicine, I know that you've obtained a lot of formal training from the American Academy of Anti-Aging Medicine, and you and I both share that. And you've been involved in the stem cell therapy fellowship that they offer through the A4M. And you've also been very active in a society that I'm also involved in and very, very fond of, and that's the International Lyme and Associated Disease Society. So I'm sure many of my viewers know that that's a group of clinicians globally that focuses especially on Borrelia burgdorferi, the causative agent of Lyme disease, and many other associated chronic infections and the role that they play in chronic illness. So I know that we'll probably learn a little bit more about you as we talk, Andrew, but welcome.
Thank you. And yes, when I remember the phone call that we had, you were looking at Forum Health, and I was so excited to have another Texan in the group. Yeah, I practiced in fact, that's what drove me to integrative medicine. Is I practiced in a little town in Texas for about 10 years. And when you're in a teeny tiny town of only 2,000 people, you keep seeing these people, and you have to confront your failures over and over. I think in a big city, if I had started out practicing in a big city, I might still just be an ordinary family doctor that took care of my patients and cared about them, but never saw, wait, this isn't working. Because I think those patients go see somebody else if it doesn't work after a while. And when you're in this little tiny town, they don't have a choice. They can either see you or drive 2 hours to Amarillo or 3 hours to Lubbock. So that was a great incubator for me for becoming, I think, a physician that listened better and tried to make some changes in the way that I approached people, because what we're trained conventionally in doesn't have all the answers. It has good answers, but not all the answers. So that was a great experience for me, which puts Texas a very important part of my career and my life.
And I think that's a mark of a really good healer, is somebody that doesn't accept mediocre results. And the same thing happened to me in Colorado. I was practicing ear, nose, and throat, and I was getting all these referrals from all my other colleagues in multiple specialties. And we were running them up against patients that we just flat out couldn't fix. We could fix a lot of things and we could improve a lot of things, but I was seeing people that were just had complex illness. And by using the traditional treatments I'd learned in ear, nose, and throat residency, surgery, medicine, steroids, antibiotics, we just weren't getting these people truly well. And it wasn't until I started to look for other answers that I really started to find what was working for these situations. And I know you feel the same way. And actually, in learning more about Ty Vincent, who's going to be somebody we're going to be talking about here in a minute. I think he's that same kind of individual.
Yeah.
You know, he was practicing family practice in Alaska, and he just wasn't accepting the fact that people just didn't get better.
That's right.
Because he wasn't focusing on root causes. But we'll talk more about that. And I know when we got ready to prepare for this discussion, and that you were going to give us a lot of information about what you've learned about the use of low-dose immunotherapy in your practice. And now, fortunately, I have it available as a tool for my patients because of our association. We talked a little bit about the fact that I'd introduce the concept, and maybe a little bit of the history of low-dose immunotherapy, but it's actually quite interesting. So I'll just share a few thoughts right now, and then we'll expand on those as we go forward. So, you know, Andrew, that I actually practiced more traditional allergy treatments as part of my ear, nose, and throat training, and that for many years I practiced traditional shot immunotherapy, subcutaneous injection immunotherapy for foods and pollens and animal danders and molds and that sort of thing. But I knew about low-dose immunotherapy, and it turns out that in 1911, a couple of clinicians, Leonard Noon and John Freeman, actually started to play around with injecting patients with a mixture that they were able to get from hay to treat what was then known as hay fever. And these guys were looking at hay fever as actually an infection, which we now know that it's not truly an infection. But by injecting people with little extracts that they were able to get from hay, and they were looking at it sort of as a vaccination process, much in the same way that Jenner in 1700s had been able to cure smallpox by injecting something from the smallpox infection. And they got their patients better. So it obviously started to create some interest in the whole concept. It wasn't until a few years later that they began to understand that it wasn't an infection, and it was actually a concept that they were creating a change in the immune system, specifically creating what we call blocking antibodies, which are these immune proteins made by the immune system that actually block the effect of allergies. Allergies comes from an immunoglobulin called immunoglobulin E, and the immunotherapy was in generating a blocking antibody called IgG. And so that was really exciting. And then subsequent, more work was done in that area. And then in the 60s, an ear, nose, and throat doctor, have to put in a plug there, in London, actually injected some nasal polyps of his patient with a mixture of what he thought was the enzyme hyaluronidase. Apparently, it was available to him, and he injected his patients. Well, lo and behold, some of the polyps got a lot better, but they tried to reproduce that and were unable to. And subsequently, they found out that it was some beta-glucuronidase, which is a different enzyme within the hyaluronidase as a contaminant that was actually having the beneficial effect on the polyps. So a guy named Leonard McEwen, who actually was a colleague of Popper, started to work with this beta-glucuronidase, and he learned that he could use the same kind of substances that they were using for general allergy, which was mixtures of pollens and animal danders like dog and cat and dust mite and so forth, very, very tiny amounts mixed with this beta-glucuronidase, and was actually able to see beneficial results. So he actually termed that enzyme potentiated desensitization. And he did that for a number of years until a guy from this side of the pond, Butch Schrader, William Butch Schrader, practicing in Santa Fe, New Mexico, and an active member of a society that I know we've both been involved with, the American Academy of Environmental Medicine, started to play around with Dr. McEwen's technique. And actually, he coined the term low-dose allergen, or LDA. And he actually got a bunch of his colleagues involved, and they did a lot of studies from about 1993 to 2001, and had some very good outcomes. Unfortunately, the FDA started kind of taking a look at what Schrader and his colleagues were doing. And actually in 2002, the FDA, in their wisdom, outlawed the import the beta-glucuronidase and the antigens that they were being able to import from England. So that caused sort of a major issue at the time. At the same time that Dr. Schrader and his colleagues were playing around, and Dr. McEwen in England, there was a guy up in La Crosse, Wisconsin named David Morris, who was actually playing with, instead of injecting people with immunotherapy in shot form, he actually started to administer the same kind of antigens under the tongue. And he actually developed a technique that we now call SLIT, or sublingual immunotherapy. And I had actually been practicing that after I went up to Wisconsin and trained with his, actually it was his daughter and some of the colleagues after Dr. Morris had passed on. But so we began to find that you could administer antigens under the tongue to the floor of the mouth. It turns out it's an immunoprivileged area that we might talk more about. But then takes us on up into about 2010 or so. And one of Butch Schrader's students, a young man named Ty Vincent, who was a family practitioner in Alaska, began to study under Dr. Schrader. And then he actually has expanded the practice of using low-dose immunotherapy with or without this enzyme beta-glucuronidase. And one of the things that Ty has done is he's taught a lot of other practitioners through the American Academy of Environmental Medicine, and maybe you'll tell us how you actually trained, because I know you spent some time with Ty. The other thing that Ty began to do is he began to look at the role that desensitization immunotherapy, and he actually prefers to call it the development of tolerance, the role that it can play to regulate the immune system's response to a whole wide variety of bad germs or pathogens in the body, everything from viruses to germs like the Lyme disease germ, parasites, yeast funguses, and molds. And he's just done a lot of work to take it forward, this concept, but he prefers to use the term low-dose immunotherapy, and he likes us to think about it as a tolerance-inducing response. And what we've learned is that blocking antibodies do play a role, but it turns out that there's many other ways that administering a substance that a person might be reacting to can actually change or modify the immune system. We've now learned about ways that Treg cells, which is one of our subpopulations of lymphocytes, actually plays a role. And there's a lot of ways that all of the areas of the immune system, not just the IgE mediated, but even the innate immune system and the cell-based immune system, can all respond in this way. So anyway, having given this background, why don't you tell us a little bit about how you got involved in LDI and some thoughts that you have about its place in your toolkit?
You bet. In that introduction, two thoughts came to mind that I think are worth mentioning for the listeners. These guys in 1911 that said, hey, let's try this. You know, they were standing on the shoulders of someone else who had done something similar in Jenner with a vaccine, right? So it made a little bit of sense, and they were willing to take a step forward into the dark with some assumptions. Now, those assumptions turned out to be wrong. Hay fever wasn't an infection, but it made sense, right? And I think that that's how we advance through science is we take stuff that we know, and when we know something, we understand it as well as we understand it at that moment, and we advance it. And then we sometimes realize, what we knew wasn't quite the whole story. And I think it's that capacity to check our assumptions at the door and say, okay, what I understand is this, and therefore we're going to move forward with it. And if what I know isn't quite correct, that's okay. We can still move forward. That's what's so great about integrative medicine and how science is advancing, and it continues to advance even today. And you look at the work from the beginning to where we're at now with Ty Vincent's sort of spin on it, if you will. And it's really exciting to be able to allow ourselves the humility to say, oh, I guess it's not all IgE, or I guess it's not all infection, or whatever thing.
I love that. Yeah.
Yeah. I would say that I probably had a similar experience personally that led me to low-dose immunotherapy. So I had been taking care of Lyme disease patients for at least 3 years. And I think when you first see patients that are chronically ill, whether it's fibromyalgia, chronic fatigue syndrome, IBS, whatever it is, some rheumatologic disease, mixed connective tissue disease. It's loosely got a diagnosis around it from conventional medicine, but trying to figure out the cause, you get a nugget of truth and you're like, oh, look, this is real. And you just go down there headlong and you're like, oh, everybody has Lyme disease. And I made that mistake, right? Everybody that came in sick had Lyme disease, and I was just going to prove it. I was going to find it. And that was a mistake because they didn't all have Lyme disease. Some of them had other stuff. And the ones that did, like, so let's say I proved one had Lyme disease. I'm like, look, see there, here's the test. You have Lyme disease. And I put them on antibiotics. About 20 to 25% made tremendous improvements. Well, that's not very good, 25%, right? Because 75% still aren't that much better. Most of them, I would say the vast majority of them had, well, that's not even true too, not the vast majority. A meaningful majority had improvement, right? If they came in and they said, well, I'm about a 3 out of 10 on the scale of how good I feel, and I put them on antibiotics after proving they had Lyme disease, most of them would say, well, I'm a 5 out of 10 now. And there was a chunk of them that were felt worse along the way, right? Only a small fraction said, wow, I think I'm better. It became clear, because you keep doing the same thing and you can't get different results, it became clear that there's more to the story. And so as you're searching and looking, it just makes sense. Hey, this problem is not just the infection. It's also how my body is responding to the infection. And maybe even the word infection isn't right. Maybe I should be thinking about it differently, and it's more colonization than infection. And I think both physicians and lay people think of, if my body has a bacteria in it, that's an infection. And when that's simply not the case, we know as integrative physicians that we're covered in bacteria, viruses, protozoa, funguses, parasites. They're not infections. They just live on us, right?
And inside of us too. I think
we're inside of us, in our mouth, in our nose, in our blood, in our joints. They're everywhere. We are the earth for them. That's the example I use. I'm like, well, I don't think the earth as a thing is looking at plants and animals as infections. We're just living here. We're using resources from the earth. And none of us want to kill the earth. If we did, where would we live? And I think that's the same thing is true of these microbes that use us as their place to live. It's almost like Dr. Seuss and Horton Hears a Who, right? They're living on the clover. And so most pathogens are only potentially pathogenic. They won't make us sick as long as the population balance is appropriate. So once that concept started to make sense to me, then I said, well, there must be something more to how do I calm down the immune system to certain things. Because as a Lyme disease doctor, when you go to ILADS and you're trained, and I love ILADS, I'm actually on the board at ILADS, I'm the secretary this year, and I think it's a fantastic organization. But again, that's sort of like being a Texan. The reason I think it's fantastic is because it helped me become what I am, right? It doesn't mean that everything that they do and stand for is 100% right, because I don't think it's all infection, not now. And I think most doctors at ILADS would say that, but not all. And maybe that's probably the beauty of Forum Health, is we bring each other all these perspectives. But so I started to do things, and one of the early things that you do, and I'm sure you do this as well, Dr. Taylor, is low dose naltrexone, right?
Sure.
You give people low dose naltrexone because you're trying to modulate their immune system. So I'm looking at ways to help people's immune system. And sincerely, I don't know how I stumbled into Dr. Vincent, but I heard about what he was doing, and I said, I've got to know more about this. He sells a manual to help you learn about it, right? And that was not good enough for me. I called him up and I said, hey, can I come up to Alaska and learn this from you? And he was like, oh, sure. Nobody's ever really done that before, but yeah, come on up. That's fine. It was fantastic. This was probably 6 years ago, maybe.
How much time did you spend with him?
3 days is all.
Wow.
And then I spent some time out on the water on the fishing, right? So,
sure.
But nicest guy in the world. And every bit like you or like me or like almost every other integrative physician, he's trying to find the answers. And he's not dogmatic in that he has all the answers. He's just saying, I think I'm onto something. Let's see how I can make it work for people. Very giving and loving guy that wants everyone to do better. So I really enjoyed that. But essentially, from talking to him, he said, look, I had studied this with Dr. Schrader, and it seems like what we were treating before were foods and environmental things. But the same concept could make sense for these microbes that live on us and live in us and are stimulating the immune system to overreact or misbehave. And so he had started with yeast, actually, and that's a common thing for integrated physicians. And it's a common thing. Patients come to me and say, I think I've got yeast, right? And you treat people for yeast over and over and over, nystatin, diflucan, sporanox, whatever you're giving them, and they get better, and they stay better as long as they're on it. And you stop it, and they get worse. And it's this weird conundrum of, am I just not able to kill it, right? And probably the answer is yes, you're not able to kill it. But the other big part of the answer is you don't need to kill it. Another example I use with my patients, it's like dandelions in the lawn. I can treat dandelions regularly in my yard, and they come back regularly in my yard. There's a point at which I'm probably doing more harm to the earth, to my lawn, to my children by overspraying for these dandelions. To some extent, what I need to get accustomed to and content with is looking out at my lawn and saying, those are really beautiful little yellow flowers, as long as there's not too many of them.
I like
right?
that. Yeah, exactly.
And I think that's to me, the balance of low dose immunotherapy is we do want to reduce the number of potentially pathologic microbes if they're too high, right? If they're not too high, let's just be content that they're there. But let's learn to accept that they're there and be okay with that. And that's where I think Dr. Vincent's discussion about tolerance is so valuable, that as we can improve our tolerance to the variety of things that our body has to be exposed to in the world, we then don't have this inflammatory cascade constantly.
So let me just make sure I'm getting this straight. So what you're saying is that in some cases, a germ, like let's just say the one that causes Lyme, Borrelia burgdorferi, could actually be in our body and actually coexist with us and not necessarily be a cause of disease.
I absolutely believe that. And I think the evidence, the population type evidence certainly supports that. If you look at the number of people that live in Connecticut or Massachusetts or New York or Pennsylvania that have been bit by a tick, they've been treated by their local physician for Lyme disease. They know they had Lyme disease because they tested positive on a Western blot. They've been treated for 2 weeks, and now they're fine. Did we kill all of the Borrelia burgdorferi in 2 weeks? Based on big numbers and math, almost impossible. Can they live with a small amount in their body? Yes. Now, how many people got bit by a tick, didn't go to their doctor, and are still perfectly healthy? Huge numbers. I would say that Lyme disease is a chronic disease, and probably, and this, I'm making this up, I'm just guessing, 10% of the patients that have been exposed to Lyme disease will have a chronic problem as a consequence. The other 90% just have that microbe living in their body, just like you or I have strep B or staphylococcus living in and on our bodies. And I don't have impetigo just because I have some group A strep living on my skin. It's just not enough for it to bother me. Does that make sense?
Absolutely. In fact, I think what more and more of the research is showing, because now we're beginning to be able to prove the presence of more and more microbes in and on our bodies because of some new techniques that we hadn't had in the past. Some of these are called DNA, PCR analysis and whatnot, because many of these germs, they can't really be readily recovered or cultured or even seen under the microscope. But I think what we're finding is that most of us have any number of microbes, both good and bad, in our bodies, and that for most of us, depending on our resilience, the state of our immune system relative to inflammation, we coexist and oftentimes have no symptoms at all. I mean, right. I know that discussion is coming about now because of COVID-19, whether or not there's asymptomatic infections or not, and I believe what we're finding is that there indeed are.
That's right. I like this example. I think it'll be good for the listeners. So think of your microbiome, the bugs that share your space with you, like your neighborhood. And in your neighborhood, you probably have a few people that you really like. You hang out with them on Fridays at barbecues. If you went on a trip, they'd check your mail, they'd watch your cat, right? Those are symbiotic neighbors. And we have some symbiotic bacteria in our microbiome, but they're not the majority. In our neighborhood, we also have a bunch of people that we know we'd wave to if they were walking their dog. But if they were to move away, we wouldn't send them a Christmas card. We might even forget their name. We might not even know their name, but we're friendly with them in that sense of they're not bothering us and we're not bothering them. And in your microbiome, that's your commensal bacteria. And then you've got this group of neighbors. They're not the greatest neighbors. They drive too fast. they play their music too loud, maybe they park on the grass, whatever, they litter, but you're not moving away from the neighborhood just because one or two of them live there. It's still a good neighborhood overall. Now, those are what I would say they're the potentially pathologic neighbors. As long as the population doesn't grow too big on that side, you're still content. You love your neighborhood. And that's what our microbiome is like. As long as those potentially pathologic bacteria don't overpopulate, we're just fine with them being there. So I think help listeners get it and say, oh, you're right. I can have some E. coli, or I can have some strep, or I can have some Lyme, whatever it is, some yeast, and my body's still super healthy.
Yeah. And I think that's the thing that was shocking to me. When I went to medical school, which is a long time ago, we were told that the brain had no organisms. Unless you had a flare of active meningitis, bacterial meningitis, you had a sterile brain. And now we know that even the brain has a microbiome, has any number of germs, and that sick brains have a different microbiome, it seems, than healthy brains. So, well, having
it really
said
speaks to the biological necessity of community. No place is in a bubble. So.
Exactly. But now, having said that, let's kind of move back into what Ty taught you and where that's taken you and your ability to help not only people with Lyme, but lots of other chronic conditions as well.
Yeah. Let's hone down into low dose immunotherapy. That's what the listeners are.
Great analogy, though. I love that.
So the objective of low dose immunotherapy or any of the other preceding approaches to re-educating your immune system is to give you very tiny exposure to the thing that your immune system is upset about. I think at a fundamental level, that's what's happening. So if it was hay fever in the 1911s, they gave people antigens of hay. It really is delusional. And this is, I'd love your take on this as well, Dr. Taylor, because this is where some people really struggle. I had a patient that I gave this to, and he was really upset to find out the way that the dilutions worked. There could be such a low dilution that there would be no more of that antigen in there. But what happens is you make a solution. And for example, with Dr. Vincent, when I first started working with him, I think he had 16 antigens in what he would call his Lyme mix or the tick-borne mix. And so it had some Borrelia burgdorferi, some Bartonella, Henselae, some Babesia duncani, some Babesia miyamotoi, Ehrlichia, Rickettsia, a number of different tick-borne bacteria. And he put them all into a solution in some water, and you can kill the bacteria just with heat, and then you can run that through a 5-micron filter so that you don't have any live bacteria, because this isn't a vaccine. Like a polio vaccine could be a live vaccine. This isn't in that regard. So all you want are just the outside surface proteins, the pieces and parts that your immune system sees, because that's what your immune system reacts to is these little outside surface proteins, like a bloodhound, the smell, or, in the picture.
They call those epitopes.
That's right, yeah.
Epitopes, yeah.
So it's the epitopes that you're trying to make a mixture of. And then you take that and you take a drop of that and put it in 10 milliliters of water and mix it up. And then you take a drop of that solution and put it in 10 milliliters of water and mix it up. And so each time you're getting a 1% solution. You're putting 0.1 ml in. And so it's 100 times weaker with each dilution. And what I think physicians and scientists have found across the past 100 years is that somewhere between 6 times dilution, or 6C, so it's 100 times weaker with each dilution, and a 9C dilution, it tends to be where most things work, but it depends on the bacteria. So not the bacteria, the microbe, I should say. With yeast, it may be different than with Lyme, and with Lyme, it may be different than with mold, and with mold, it's different than with the Epstein-Barr, where that range is generally.
So let me just interject. I know that the 6C, which is diluted 12-fold, is actually 1/1,000,000th of the concentration of the stock solution. So we are indeed talking about very, very weak concentrations.
Yeah,
even at the most strongest one.
At that dilution, and I don't know, maybe we don't want to go into this. You can cut me off. But at that dilution, we still have epitopes present in the solution. If you were to dilute out past 12 to 13 dilutions, now there's arithmetic reasons to believe that we no longer have any epitopes in the solution. And yet,
or it would be just a random statistical
Right. If
happening
there is one, it just was,
by
you just happen
accident.
to have one in that solution.
Yeah.
And yet with Lyme disease, for example, I find that somewhere between 18 and 23 dilutions is where they really respond well. And so you're looking at a homeopathic dosing schedule, and that probably makes sense to a lot of your listeners and maybe doesn't make sense to others.
Well, it does bring up the whole concept that we probably won't go into of the energetic or the vibrational effect
Right.
of what we're doing.
Right.
Almost
and that's where I
looking
think
at it from
people like me have to swallow our assumptions and just leave them at the door and say, I don't know, but I know that it works at that energetic level. And
I'm kind of like you. I've been
uphill
trying more and more because I'm so science, physics, and chemistry, biochemistry based. Everything is molecules and atoms. That
Right.
it's harder for me to understand things at the electron, neutron, proton, energetic level. But
Right.
yet, I mean, I think if you look at Chinese medicine and acupuncture and frequency specific microcurrent, there's no question that there's a whole nother realm of healing. And I think maybe we're getting into that in some of the
and you addressed it
weaker
nicely.
dilutions.
You sort of described it nicely by saying sort of atoms and molecules versus electrons and neutrons. And I guess it's the Newtonian versus quantum physics. But leaving that discussion out,
Yeah.
because I think if we go into it that much, then patients are saying, okay, I understand enough to not understand. If we don't bring that up, the reason I bring it up is because when I haven't brought it up with patients and then they're like, wait a minute, I did the math, then it's bothersome to them. So I think we need to at least bring that up and say, hey, this is how it's going to work. And for some things, it's still going to be inside that Newtonian epitope experience. And for some things, it's going to be outside of that. And it's going to be neutrons and electrons and waveforms. But it is dilutional. And this is where the nuts and bolts of what happens for patients. So a patient that comes in and they believe that they have a yeast infection. And sure enough, you showed that they do have a yeast infection. And they've been having multiple vaginal yeast infections. And you can periodically see yeast on their tongue. Well, it would be, in my opinion, silly to not decrease the amount of yeast that they have growing in their gastrointestinal tract. Because, of course, their immune system is upset about that vast amount of yeast that they have. And you do want to lower that meaningfully. And they probably, in my experience, won't recover completely if that's all you do. You have to then take the next step to retrain the immune system to say, this yeast that was overwhelming you and putting you in a state of hyper alertness with regard to your immune system, it's okay. There's still a little bit there, and you're going to learn to get along with it, and you can be tolerant of it, and it will not overwhelm you and kill you. And that's where low dose immunotherapy comes into play. And so what you do is you start someone at this low dilution and then slowly increase it until you find the dilution that relieves them of the inflammatory symptoms that are being caused by the immune system rather than by the microbe itself. And I can go into lots of details about how to do that, and I think I should, but I don't know. I've been talking and talking. I want to give you time to ask any questions.
No, that's okay. But I think this might be a really good time for me to interject for our listeners. And I'm sure many of you already know that what Andrew and I are trying to do is try to introduce you to some educational concepts about low-dose immunotherapy. And we're certainly not proposing to recommend how you might treat any specific disease or that how you would treat your own condition. So obviously, if you have a condition that you think might benefit from low-dose immunotherapy, we are available. Both Andrew and I and the other doctors at Forum Health would be more than happy to talk to you more about your individual condition and how low-dose immunotherapy and some of these other tools in our toolbox might be useful for your own condition. But I know we focused so far a little bit on the role of LDI for Borrelia burgdorferi or Lyme infection, and I know that Ty, when he treats that group of diseases, he actually combines a bunch of the different germs together in one dilutional mix, and then it seems to work fine regardless. But one of the things that is important for LDI to work is that we have to have the right agent. In other words, the germ that seems to be bothering the immune system and causing the immune system to cause us self-injury in the form of inflammation, it has to be present in this mixture if we're to help develop tolerance. And in addition, as you said, the proper dose is also critical. And one of the things Ty emphasizes is that if you use too concentrated of a dose, you can actually trigger an increase of symptoms, which is usually just an increase of the symptoms that are already bothering that particular patient. It's not usually new symptoms that they've never experienced before, but it can be pretty significant. And he always says that I don't like to trigger a worsening of symptoms with a dose of LDI, but at least if I do, it does give me a pretty good idea that we've got the right agent. And then from then, it's a matter of getting the right dose that's typically more diluted. And finally, when you get to the right dose, it's quite amazing the way the symptoms actually just get turned off.
That's right.
But what are some of the other things besides yeast and Lyme that you've had some success with?
Sure. Well, there's lots of things I've seen success with. Obviously yeast and Lyme, but IBS, there's a whole, so let me back up a little to the Lyme. When I said that when I started working with Dr. Vincent's solutions, there was only, I think it was 17 antigens. There are now 74 antigens in the vector-borne or the Lyme-borne mix. He's been able to add more things. And so now we're finding people that we had treated before that didn't really get the response are now starting to improve. And like you said, that's because I have to show you the antigen that's bothering you for you to calm down to it. And he's made a number of different mixes, and he continues to make them. There's one for IBR, Irritable Bowel Syndrome, and it's really what it is. It's primarily flora from the colon that is normal for most people, but some of us overreact to that bacteria. And so those are the patients that will then develop IBS, and it seems like it's really difficult to treat. Well, it's just because they have the same bacteria that you and I have, but they just really get reactive to it. Sort of like some people are afraid of heights. Some people live in tall buildings and don't have any fear at all, right? So
like H. pylori and
H. pylori has a lot of things that it'll trigger. One of the things that was really fascinating about H. pylori, vitiligo, when they've got these areas where they don't have pigment on their skin, that seems to make a big difference for a lot of those. It's actually an immune response to H. pylori, which is a normal bacteria found in our gut. Now, it's a potentially pathologic bacteria because it can cause ulcers, but just like most other things, we don't eliminate it when we treat it. We reduce the population significantly when we treat it the conventional way, right?
So let me get this straight now. So you're saying that a germ that normally resides in our stomach or our intestine can actually play a role in loss of pigmentation of the skin?
That's exactly right. Yeah. In fact, the skin, maybe you're setting me up to give you the answer, but the skin is really, really just a demonstration of what's going on in our gastrointestinal tract, whether it's psoriasis or eczema or vitiligo or acne. These are all manifestations of what's happening in our gut. Our skin's a detox organism, like our gut's a detox organism, and it's a place where we can see the inflammation that's happening. So skin diseases they're not exclusively immune. You can have skin cancer, but skin diseases that are those ones where we're like, well, take a steroid. Okay, it's an immune disease. And low dose immunotherapy, if we do the work, potentially we can figure out the triggering thing that's upsetting your immune system, the triggering epitope, the triggering antigen that's upsetting your immune system. A lot of times it's a microbe, but actually it could be a mold toxin. I know you do a lot of work in environmental medicine, and mold toxins, as we get rid of them out of our body, patients' brain fog and fatigue and POTS syndrome, all those things, dizziness, it improves, but they could still have an immune dysfunction to the mold toxicity, and they haven't eliminated every last mold toxin. It's dilutionally difficult to do that. And so low-dose immunotherapy for mold is a great thing. I use that all the time for my mold toxin patients.
Sure. And I think it's important for our viewers to know too that in addition to all these living things, these microbes, that the immune system can play an inflammatory role with chemicals and with heavy metals and other things besides just living microbes.
One of the ones that was the most surprising to me was progesterone. You know, when you first start into integrative medicine, you start to say, well, if I help these people with their thyroid and their hormones, I will be supporting their capacity to repair, right? And so you put people on hormones and they are able to repair a little bit better. And I've had a number of patients, not a huge number, but a number of patients that every time you put them on progesterone, they feel bad. They feel achy or tired. And I at first thought it was just the hormone, and it didn't make sense. I actually talked to Dr. Vincent about that when I was in Alaska, and he was, I've seen that too. And I actually desensitized some women to progesterone, and now their periods, and these are the people that their periods are horrible, or when they're pregnant, it's like they're hit with they feel like they're going to die, and they are sensitive to their very own hormone, and you can desensitize them to that. It's been fantastic, using low dose immunotherapy for progesterone for some patients that react so poorly to that hormone, which was very strange to me, that the immune system would react somehow adversely to a molecule that we make.
Well, yeah, and I think that's one thing that we might want to emphasize is that the immune system has to do two things. First of all, it has to learn to react to things that would hurt us, and that's the immune response. But at the same time, it's equally as important that it learn to accept or tolerate things that we need, all of our nutrients, our hormones, things like that. And what can happen is sometimes that process goes awry. And I always tell my patients that it's any perceived threat by the immune system that is of concern to us. And that's the reason that so many people develop so many food allergies, to things that would obviously never be a threat, to us. But yet by the same token,
and you probably have a similar experience, that once the immune system starts to spiral out of control, it gets worse on all fronts. And so whether the straw that broke the camel's back was when you got exposed to mold, or when you got bit by a tick and got exposed to Lyme, or when you got pregnant with your third child and your progesterone went way up, or when finally the threshold of the lead that you had accumulated over your lifetime, whatever it was, that's not the problem. That was just what caused the immune system to finally start to overreact. And it began to overreact to all those things. So with low dose immunotherapy in my Lyme patients, or honestly all my patients, I start out by saying, I think the biggest trigger is, this, and let's desensitize you to that. And it's really interesting when they'll say, well, my headaches are gone and my joint pain's gone, but my brain fog hasn't changed a bit and I'm still exhausted. Okay, well, I know that the immune response to Lyme that you are having is headaches and joint pain. And now we've got you on the right dose for that. We're giving you that dose every 7 weeks. You're continuing to have improvement in those two things. I better find the next antigen, the next pathogen that is bothering you, that's causing the brain fog and the fatigue. And so then you just go down the ladder and you just say, okay, I think the next thing is mold. And sometimes you're right and you just get, hit after hit after hit. Sometimes you're wrong and you strike out a few times before you hit another single or double. And I have a woman that I saw yesterday who I treated for Lyme, and I know she has Lyme and Babesia because these aren't like lab developed tests. This was her Western blot and her WA1 antibody were both high. So I know she has those two diseases, and low dose immunotherapy did nothing for her. And because of that, we sort of moved away from it, put her back on antibiotics. She got back to sort of this plateau of good enough to function and go to work. And it didn't dawn on me till yesterday, and I apologized to her. Maybe we should do low dose immunotherapy for something else. We started her on low dose immunotherapy for yeast yesterday. And it's just one of those errors that you make, or sort of oversights of saying, just because it didn't work for that doesn't mean there aren't other things your immune system is mad about. And I think that that's really key for people to understand, that your immune system could be upset at one pathogen, one environmental exposure, and you could have another one that's simply causing inflammation, but not through the immune response. And that's why it's this stepwise approach that integrative doctors like you and me take.
Yeah, and I like what you were talking about, how the tendency to spread, to develop more and more sensitivities is often seen, and that can work the other way too. Sometimes you desensitize the body to one of the major antigens like yeast, for example, candida, and lo and behold, all the food allergies can go away.
Yep, that's right.
Kind of amazing. And then I know you talked about the straw that broke the camel's back, which we see all the time, but how often do you find that straw that breaks the camel's back in terms of this immune inflammation is actually a stressful life event?
Sure. Yeah. It's
comment about that. Give us a couple of vignettes about that. I know I see that all the time.
The one that was weirdest to me is I saw a patient who was very healthy. And here in Park City, they had the Olympics here in Utah back in 2002. And in Park City, where they had the Olympics, they've got a bobsled that you can still go on. And it's not ice, it's cement, but it's really cool. And she went on the bobsled for fun with her family. And she rattled her head around. And ever since then, she had this severe fatigue. But all of her symptoms sounded like Lyme disease. Well, there's no way she caught Lyme disease riding the bobsled. That doesn't make any sense. When I tested her, sure enough, she's positive for Lyme disease. Well, why didn't it bother her before that? Well, I don't think it bothered her before that because it, you know, her immune system, her inflammatory cascade hadn't gone off the rails. I was naive enough at this time to try to treat her with antibiotics. Well, think of how silly how much sense that doesn't make at this point. It couldn't have.
She probably didn't have any more bacteria after she rode the bobsled.
That's right. Yeah, exactly. So why would I do that? Because
Yeah.
at that point, I hadn't discovered low dose immunotherapy. That same patient comes in today, you treat them with low dose immunotherapy, you calmed back down the immune response that got triggered by just a physical trauma, right? Emotional traumas are the same way. The death of a loved one, a divorce.
Or even a pet.
Yeah.
How many people in our practices right now, Andrew, because of this pandemic, are seeing a major exacerbation of clinical symptoms, whether it be fatigue or headache or aches and pains or gut symptoms, you know, bloating and diarrhea. I mean, I'm seeing it all the time.
That's right. Yeah. So whether it's, I tell my patients, emotional stress, physical stress, nutritional stress, they're all going to cause similar things to the body. And so as integrative doctors, we're constantly talking about how to reduce those things, but we also have to keep sort of our ear to the ground to say, okay, what's the stress that triggered this? So that then I can see what should I do? How should I respond first? Because if I had had that insight when this woman came in years ago, I would not have started treating her Lyme disease with antibiotics, right? Because her infection level didn't go up after a ride, but her immune response could have changed because of the stress. So
exactly. And so one of the beauties, and just from a practical point of view, is now in my practice, if I see people with chronic illness, that the usual tools, whether it be antibiotics or nutrients or diet change or lifestyle change, isn't doing everything that we want to do for that patient. We do have this option to go through your practice to also offer these patients the LDI, which is kind of nice because now in this day of telemedicine, we can actually do that without them having to necessarily travel out to where you are in Provo, Utah, but they can still take advantage of it. But why don't you talk a little bit about how your clinic and your folks, especially Amanda Watson's, able to help my patients in that regard, and could really do that for any of the other Forum Health providers.
yeah, absolutely. So Amanda, I actually took Amanda with me when I went to Alaska to train with me. She's fantastic. And she loves to do immunotherapy. So we rely heavily on the patient and their doctor. And we have a number of doctors in Forum Health. And they'll either send Amanda through the patient portal through our EMR or through their HIPAA compliant email, the vignette of the patient and their labs and that sort of thing. And then give Amanda guidance on, look, I really think we need to focus on mold for low dose immunotherapy or Lyme for low dose immunotherapy. Let's start here. And then what we'll do is we've got the different mixes, and based on the severity of the patient and the particular antigen that we're focusing on, say that it's yeast, well, we could go as weak as 18 dilutions, as strong as 6 dilutions. We're going to start somewhere in there. The sicker the patient, the lower you're going to start, because they tend to need a much lower dose to get their improvement. And I don't know why that is, but it's true. And so you'll send the patient then, and this is interesting too. We used to do it under the skin. It feels like a bee sting. People don't like bee stings. It doesn't work better. It actually makes sense to me that it doesn't work better. Our GI tract starts in the mouth, and our GI tract is full of places where we're supposed to be presenting cells to the immune system. Our skin is not the place where stuff enters our body routinely. So it actually seems more reasonable that we would do this through the mouth than through the skin. It just isn't the way that allergists have historically done it. I think it seems more medical. It's the medical theater of sticking someone with a needle. So drops under the tongue. I have one patient that does better with injections and 1,000 patients that do better with drops under the tongue. And that's not a made up number. I really do have one patient that we were doing it with drops under the tongue, and it wasn't that effective. He said, let's try the injections, and he did great. So I have one patient that's that way. But we send a syringe out that has the solution, and you're just going to squirt it under your tongue. We cut the needle off, and That way you don't stick yourself with the needle. But it's a
About,
little.
about how much is the volume of that syringe?
So it's 1.5 milliliters is the
Okay.
volume of liquid that's in
About
there.
30 drops or so, 30, 40 drops, something like that.
I'm sorry, 0.15.
Oh, 0.15.
Yeah, I'm sorry, 0.15 milliliters. It's basically a drop and a half.
Oh, okay.
Yeah, so 0.15
So
milliliters.
very
of
small
solution.
amount. Yeah.
Very tiny. You're going to squirt it under your tongue, and you just hold it in your mouth for 30 to 90 seconds. This is one other place where sometimes giving an injection could be helpful. If you have a 2, 3, 4-year-old and they can't hold it in their mouth, you're not sure they're going to keep it in their mouth, then you give them an injection. But to be honest, even our little kids, we just give it drops under the tongue because it's in their mouth. It's going to go down their throat. It's such a tiny amount. It's not like you're drinking a glass of water. So you squirt these in your mouth, and then you're going to wait for 10 days to see what happened. And you're going to email back with Amanda, and you're going to give her a synopsis of what just happened in the last 10 days. And when I explain this, it'll sound silly. Of course, these are the 3 possibilities. Nothing happened, you felt worse, or you felt better. Well, if you felt better, fantastic, because we picked the right antigen and the right dose, or close to the right dose, right off the bat. And that's not that unusual. It happens quite a bit. If you felt worse, we're not as pleased with ourselves. The good news is we picked the right antigen. We are desensitizing you to something that you have. We just went too high. And if nothing happened, this is the least attractive because I don't know now, did I give you too weak of a dose or did I give you the wrong antigen, right? Even if I have a lab test that shows you have Lyme, that may not be what's upsetting your immune system. So giving you those drops may not help. So if nothing happens, we're going to increase your dose. If you felt worse, we're going to have to wait for a period of time. There's a washout period of time to let your immune system reset. If you felt better, but it only lasted a short period of time, fantastic. We can raise the dose maybe a tiny bit. And we'll just slowly raise the dose until we find an improvement that lasts for more than a week. Once we found an improvement that lasts for 10 days or more, then we're going to give you that same dose until, and what you'll find is with each dose, it's going to last longer and longer and longer. And eventually it'll last for a full 2 months. And eventually it'll last longer than that. But we're going to redose you every 7 weeks simply because you want to re-educate the immune system. Hey, this is still safe. I use the example of it's like little boys going to kindergarten. To start with, most of them don't like to go. And so you can have some reactions where you're like, I didn't like going. But if you have them continue to go back and continue to go back, they start to do better and better and better. And now the great thing about it is they don't have to go forever. Eventually they graduate and they're done. And that's how low dose immunotherapy works is you give patients a dose every 7 weeks. My experience is that after 2 to 3 years of continuous dosing, they can stop taking it. And their immune system now remembers that this thing is not threatening to them. I think it probably is very much like your experience with the allergy shots as an ear, nose, throat surgeon, that after 3 years or so, patients say, I think I'm better now. Can I quit? And you say yes. And 70% of them, that's true. They never come back. And 30% of them say, you know what? My symptoms started to return. So they come back and you put them on the same dose and you just say, you know what? Let's do it another year or two longer. It's been remarkable.
That's exactly what our experience was. And now that under the tongue, why don't you make a comment about safety? Could this be dangerous? Is there much potential for danger?
So I don't want to say no, because I have had one patient in the years that I've been doing this, that we gave her a dose that was so much stronger than what she needed that she felt terrible for 6 months. And it was another 6 months before she felt as good as she felt before we started. She's a Lyme disease patient. And we actually treated her for Epstein-Barr because we had treated her for Lyme for a while and she was doing better. And then we gave her a dose of Epstein-Barr and we apparently gave her too high of a dose. And we didn't start very high. We started at a dose of around 20, which is a pretty low dilution. And it's backwards. The higher the number, the more dilution, so the weaker it is. And it took a good 2 years before she said, you know what? I know it's my immune system. Let's move forward on this. I need to do it. And we said, okay, great. So we started around a 20. We're going to give you a 50 dilution. That's the lowest we've.
Wow.
And there's no limit to how weak you can make it. And Amanda just diluted it 30 more times, which took a while that day. And she did okay. So you could, in theory, blow up the immune system just like that bobsled ride blew up this girl's immune system years ago for me, right? If you stress the immune system enough, you can really exacerbate it. In the years that I've done that, it's happened one time. So I cannot say that it is not without risk. We have to make sure that we're not giving you too high of a dose. And that's a conundrum. That's a real discussion between the patient and Amanda and you and me as the doctors of how do you want to do this? That's really the only risk, because all we're doing is showing you epitopes or antigens to a thing that your body is upset with. If I gave you here's one question that I get a lot. Well, what if you're giving me antigens for something I don't have, right? Like you've got this mix of Lyme bacteria, and it's not all Lyme. Some of it's Babesia and Ehrlichia and Rickettsia. And what if I'm not sensitive? What if I've never been exposed to Borrelia? Or, and I have Bartonella, but I don't have Borrelia. Well, nothing happens. You're not made sensitive to it. It's a dilution so small that nothing occurs. It would be like if you gave someone an allergy shot for strawberries, but they weren't allergic to strawberries. Well, nothing happens.
Sure. And it also, I think it's important that we mention that this is not an expensive endeavor either.
No, that's actually what I love about it. If I only had one tool in my toolbox to treat patients that have an inflammatory condition, this is the one I would choose. And that's because it helps so many. It can be so broad. It could be against so many different things, from yeast to Lyme to mold to foods to progesterone. You can even make it for them specifically, but it's very inexpensive in the long run. When you look at what people have to spend to treat Lyme disease with long-term antibiotics, or to treat even mold or environmental toxicity with, chelation and binders and on, you're looking at one dose every 2 months once we found the dose that's right. It is somewhat cost prohibitive at the beginning because you're doing a dose every 10 days. And that's hard to say, oh, geez, this is going to be a little bit of an upfront effort for me. But once we have the right dose, you're looking at, $80 every 2 months. It's very inexpensive. And there's no charge for the visits. That's how we did it. We wrapped the visit with Amanda into the cost for the dose. So you're not having to see the doctor every single time in that process. You're just following up with either Dr. Taylor or myself the same way you would every, 2 to 4 to 6 months, depending on what's going on with you. But the Low Dose Immunotherapy program exists sort of as a parallel program to seeing your physician, and you can have as many adjustments in there as you need.
Great. And, I know that Ty Vincent's YouTube channel is a real wealth of information. Have you viewed any of those videos?
I have. He's great. He's just a tiny bit better in person, but he's fantastic. I would recommend to anyone to go to his YouTube channel. Generally, when I'll spend 15 minutes or so explaining this to patients, and if they still want more information, I'll just send them to his YouTube channel and his website and say, look, this guy, this is all he does, and he can explain it exceptionally well, and please look at it, and then we can get started helping you.
Yeah, I know his videos tend to be very short. Some of his first ones, which were some of his earlier videos that he recorded about 3 years ago, he actually numbers them, LDI number 1, number 2, and so forth. But yeah, I would suggest that anybody that wants to know more about LDI that we haven't provided in this discussion, that'd be a great place to start. And then some of his more recent videos, including some of the ones he's recorded since this pandemic lockdown, he actually talks about specific conditions and maybe some of the individual antigen mixes that he's found to be most successful to treat individual diseases. But man, this has been great, I think. And I would just say, let's try to wrap this up. But Andrew, maybe you have some parting thoughts or comments as we come to a close today.
I think that there aren't very many patients out there where this couldn't be a helpful tool in the toolbox. I guess parting thoughts I would share are, and I think you'd probably agree with this, it makes an enormous difference in the effectiveness of any immunotherapy, anything that we're going to try to calm down your immune system, if we get your gut healthy first. And so if you skip right to this step and you haven't done the work of decreasing inflammation in your gut, it won't work as well. And in my opinion, that's when people say, oh, this didn't work for me. Well, that's because we didn't get your immune system calmed down broadly by getting your gut healthy first. So that's one thing that's important. I do find that when patients take low-dose naltrexone, their low-dose immunotherapy works better. So I like to use that in conjunction. I think what you said about Dr. Vincent, he has spent years studying this and can say, hey, for that specific condition, you know, ankylosing spondylitis, I find that this particular mix works better. So if you have a condition that's been diagnosed, whether by an integrative doctor or a conventional doctor, it's probably an accurate diagnosis. And so we can find, just go to, you know, his catalog, and I've got it, and, you know, you can get a copy of it while in. We can find the antigen that makes the most sense for that patient, even if we don't have lab evidence of that you have this bug. And then the last thing I would say, just so that people can sort of anticipate how broad this is, if we cannot figure out what's wrong, we can make an autologous mix, which means it's made to you specifically. We get you to give us some urine, some saliva, some scrape off your skin, maybe some blood, and you can mix all of that up. And then you can take that and we can desensitize you to whatever it is that's causing inflammation in your body. It's not foolproof, but we've done that before, particularly for things like interstitial cystitis, where people feel like they always have a urine infection, and it's been very effective. So really the sky's the limit with regard to the ways you can do this.
Well, Andrew, I really appreciate all the wisdom of your experience from this, and I know that it's an exciting tool that we have now in my toolbox. Glad to have been able to add that one. So we'll have to carry this discussion on and talk about some of these other things that we just briefly touched on today, the gut, mold, you know, chemicals, so forth and so on. So thanks so much, and we'll get this uploaded to our YouTube channel, and we'll spread this around through some of the forum platforms. But Andrew, I hope you have a great weekend, and thanks for taking the time to chat with me today about this.
Thank you, and thanks for doing this, Wally. You're a great host, and I have enjoyed tremendously being able to work with you. This is one of the great things about Forum Health. So thank you.
Absolutely.